Welcome back to Decode Healthcare with Harshal. I'm your lead instructor, and before we jump into today's lesson, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, let's get into it. Today, we are looking at something completely foundational. We often think of a patient's medical record as, just a clinical history, a log of their symptoms and treatments. But in the inpatient world, that medical record is actually a literal financial blueprint. Every single word, every test, and every diagnosis determines the exact reimbursement a hospital receives. It ultimately dictates their financial survival. So, in this explainer, we're going to decode exactly how that works.
Okay, let's dive into this. Our roadmap for today covers the foundation, sequencing, and POA, the role of CDI, when to query, and we'll wrap it up with the real-world impact.
Starting off with Section 1, the foundation, or the anatomy of a DRG.
To really grasp inpatient reimbursement, you absolutely have to understand the diagnosis-related group, or DRG. Originally cooked up back in the 1980s, a DRG is basically a statistical system. It groups inpatient stays into categories for patients who are expected to use a similar amount of hospital resources. Today, the modern version utilized by CMS, the Centers for Medicare and Medicaid Services, is called the Medicare Severity DRG, or MSDRG. Think of it as the bedrock of the entire inpatient prospective payment system. The basic formula? Clinical similarity plus resource similarity equals one payment group.
So how exactly does a patient stay end up in one of these specific groups? Well, it goes through a logic engine called the MSDRG grouper, which looks at a few key inputs. We're talking the principal diagnosis, secondary diagnoses, which we usually call CCs or MCCs, meaning comorbidities or major comorbidities, along with any procedures, and even patient demographics like age, sex, and discharge status. But here is the absolutely crucial takeaway. While all these factors matter, the principal diagnosis is the heavy lifter. It literally drives about 80% of the initial DRG assignment. 80%! That is massive. Let's crack open that grouper's logic engine and see how it actually filters thousands of possible diagnoses into roughly 750 distinct payment buckets. Step 1. It figures out the major diagnostic category, or MDC, based purely on that principal diagnosis. This usually corresponds to a major organ system, like the circulatory or respiratory system. Step 2, it determines the partition. It basically asks, hey, was a significant operating room procedure performed here? This splits the case into either a surgical or medical partition. And finally, Step 3, it applies the DRG triplet severity based on those secondary diagnoses. Does the patient have an MCC, a standard CC, or neither? Each of these steps refines the category until we hit the exact payment weight.
Moving right along to Section 2, Sequencing and POA Indicators. Remember how I just said the principal diagnosis drives 80% of the DRG? Well, getting it right is, quite frankly, everything. According to official coding guidelines, the principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission. Now, I really want to emphasize that phrase, after study. That's the key. If someone comes in with severe chest pain, well, chest pain is just the admitting symptom. If, after running all the tests, the doctor determines it was an acute inferior wall myocardial infarction, that confirmed condition becomes our principal diagnosis. If a coder just logged the symptom of chest pain, the hospital's financial blueprint would be fundamentally broken, leading to a huge underpayment. And this brilliantly illustrates how this plays out in practice. On a standard inpatient face sheet, it officially separates the primary reason for admission, like acute pyelonephritis, from coexisting conditions, say dehydration. Getting the sequencing backward, it completely derails the entire DRG assignment. No way around it.
Now, once we've got our diagnosis sequenced, we hit another massive hurdle, the POA indicator, which stands for present on admission. Every single diagnosis has to be flagged. If a condition like type 2 diabetes was already there when the patient walked through the hospital doors, it gets a yes for POA. But, and this is a big but, if a condition developed after the patient was admitted, like a new infection or a pressure ulcer from lying in the hospital bed, that gets flagged as a hospital-acquired condition, or HAC. And let me tell you, confusing these two statuses is incredibly dangerous, both for compliance and the hospital's bottom line. Now, what's really interesting about this slide is just how massive the stakes of that POA flag are. Consider a scenario where a patient comes in for sepsis and diabetes, but then develops a deep vein thrombosis, a DVT, after they are admitted. Normally, a DVT is a major complication that would bump up the DRG payment. However, because it's flagged as N for not present on admission, it turns into a hospital-acquired condition. Because of that, the grouper absolutely will not use it to increase the payment.
Instead, CMS is going to flag the hospital for a quality review, which often leads to a bundled payment penalty. Accurate POA flags aren't just tedious paperwork, they are literally a hospital's primary shield against financial penalties.
All right, on to Section 3, the role of clinical documentation integrity, or CDI for short.
Here's the reality. Clinical coders can only code what is explicitly written in the medical record. They can't guess, they can't assume. If a doctor writes something vague, the coder is stuck using a vague code. This table really highlights the cascading nightmare of poor documentation. Vague notes lead to incorrect DRG assignments and huge underpayments. Missed complications mess up the hospital's severity of illness scores. And worst of all, a lack of clinical justification directly causes payer denials, while aggressive coding without the paperwork to back it up, that triggers massive compliance audits. It's a real domino effect.
Let's look at these two realities side by side to see just how much words matter. On the left, we have poor documentation, admitted for chest pain. There's no link to the underlying cause. The coder is forced to use a low-paying symptom code, causing a revenue hit and compliance risk. But on the right, look at the good documentation, acute anterior wall MI. That CDI specialist makes sure the record is fully codable, compliant, and actually captures the true intensity of the care provided. Just adding the specific location and the word acute changes the whole shebang.
That brings us to Section 4, when to query clinicians.
So, a CDI query is basically a formal way to stop and ask the physician for clarification. But CDI teams can't just fire off questions whenever they feel like it. There are very specific red flags that trigger a query. They query when documentation is incomplete. Actually, scratch that, it's more like when it lacks specific details, like saying infection but missing the exact organism. They query for conflicting notes, like if a nurse's note totally contradicts the discharge summary. They also have to stop and ask if a diagnosis is ambiguous, if it's inconsistent with lab results, or if it's just completely unsupported by the clinical evidence in the chart.
When CDI specialists do reach out, their questions have to be highly regulated. They absolutely cannot lead the doctor to a higher-paying code. It has to be neutral. It has to be auditable. Here's a perfect compliant example straight from the source. Doctor, please clarify if the documented respiratory failure is acute, chronic, or both. See? This simple, direct question brings those strict administrative rules to life. It lets the physician clearly define the severity of the illness without being pushed into a corner.
Let's move to our final section, Section 5, and see how this builds into real-world coding impact.
The transformation in these two real-world cases is honestly pretty striking. In the first case, the initial note just said osteomyelitis unspecified. The coder couldn't even assign a specific MSDRG. But then, the CDI team queried for the anatomical site, and the clinician clarified it was acute osteomyelitis of the right femur. By just adding the exact site and the word acute, they transformed the case into a compliant, much higher-weighted surgical DRG. In the second case, a basic diabetes note was queried and updated to type 2 DM with neuropathy. That single complication immediately increased the DRG weight and improved the hospital's case mix index. It goes to show how a simple clarification completely protects the revenue cycle for sure. Finally, let's walk through one of the absolute most complex diagnoses out there, sepsis. The rules here are like a giant puzzle. Step 1. The coder has to identify the specific underlying infection, like E. coli. Step 2. Check the documentation for progression to severe sepsis or septic shock. Step 3. Identify and link any resulting organ dysfunction, like acute kidney failure. And Step 4. Official guidelines state that the underlying systemic infection must be sequenced first as the principal diagnosis. If even one step in this strict logic is missed, the true severity of the patient's fight for their life is completely lost in the data.
So, as you can see, the inpatient medical record is so much more than just a clinical history. It's the definitive financial and quality fingerprint of a hospital's care. Which leaves us with a pretty vital question to consider. Does your hospital's clinical documentation truly reflect the severity and reality of your patients? Something to reevaluate for sure. Thank you so much for joining me for this explainer. And hey, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. See you next time.